Hello guys, welcome to our channel. Today we are going to discuss about the psychiatry rapid revision as part of our mission 200 plus. So almost 1 to 2 3 subjects we are going to finish this rapid revision guys, and after that I'm going to release the three important videos. Okay, sure short videos, sure short 1 2 3, which will be each video consisting of the 50 topics, and those 150 topics are really important guys. Please do watch those videos and read those content. So let's start our today's discussion, psychiatry rapid revision. So before we move on to the DSM-5 criteria diseases, I want you guys to know about some of the important points. So first, delusion. What is meant by the delusion, guys? Delusion is known as a fixed false belief. Okay, this is fixed false belief. And what is the most common type in those? There are different types. In that, most common is the paranoid. Okay, paranoid is the most common type that we are going to see. And next, there are some of the syndromes that you have to take note. Otila syndrome. So what is meant by the Otella syndrome? This is about jealousy. Okay, jealousy towards the wife or towards the loved people. That is jealousy or infidelity. Okay, infidelity, which will be seen in the chronic alcohol patients. Chronic alcohol patients that you are going to see these symptoms. Next, other one, Magnon syndrome. Okay, in the Magnon syndrome, this is seen in the patients those who take the cocaine or the cocaine bugs. So they will be feeling that something is crawling on them. So something is bugs, like for example bugs are eating them. So this is like prosecution type of the delusion that is seen in the patients of the Magnon syndrome. And next we also have the Cotard syndrome. Okay, that is known as a Cotard syndrome, and the Cotard syndrome is seen in the patients of depression. Okay, in this depression patients, this is usually associated with the negativity and the nihilistic type. So this is nihilistic type, that they feel everything is happening just because of them only. Next, another one is the egg bomb syndrome. Okay, another one is the egg bomb syndrome. What is meant by the egg bomb syndrome? That the patient will be having the restlessness. Okay, restlessness will be seen in this patient, and associated with the leg pain. That is like patient will be experiencing all these kind of symptoms that is seen with the egg bomb syndrome. Okay, this is one of the syndromes that you have to remember. And also Fregoli syndrome also there. Okay, remember Fregoli syndrome. So we see the difference. There are two types. Okay, one is Fregoli and other one is the Capgras. Okay, so what is meant by the Fregoli? That Fregoli syndrome is tells us stranger is believed to be the prosecutor. So we feel that stranger is our persecutor. Okay, and Capgras is opposite to that. Known person is believed to the, for example, our wife, which will be seen as a stranger. Okay, so this is the misidentification delusion seen in the Fregoli and the Capgras syndrome, right? Next, moving on to the hallucination. So what is mean by the hallucination, guys? Usually hallucination is just perception that is without stimulus. Okay, without stimuli, you are feeling that perception. Okay, false perception that is seen here in this patient. Next, there are two important types that you have to know. The most common is auditory. The most common is auditory, right? That is seen in the schizophrenia patients. Next, there is true delusion and pseudo delusion. So what is meant by the, sorry, true hallucination and pseudo hallucination? So true hallucination, which is coming from the outer space. Okay, which is coming from the outer space. Pseudo hallucination, which is coming from the inner space. Okay, inner space. And where this is coming, this is actually objective type, and here it is subjective type. So this is the difference between the true hallucination and the pseudo hallucination. Okay, next another type also we have, that is illusion. Okay, what is mean by the illusion, guys? It is misinterpretation with stimuli. Okay, with stimuli. Stimulus is present here, no stimulus here, stimulus is present. Okay, these are the three types that you have to take note. Next, moving on to the schizophrenia. In the schizophrenia, you have to know first, when the schizophrenia is first coined by whom? This is actually coined by the Eugene. And Eugene said that there are four important A's that is important to diagnose the patients with schizophrenia. That is A for autism, and A for association, and A for affect, and another A for ambivalence. Sorry guys. So this is what Eugene said. These four important A's are given for the schizophrenia. Okay, this is one type. Next, another person like Kurt said that they are always first rank symptoms. Okay, and in that first rank symptoms, everything will be associated with the three. For example, three types of auditory hallucinations. Okay, three types of auditory hallucinations. And next, three made phenomena that is present. And another is the three thought phenomena, thought insertion. That is also seen in this patient. So what are those three auditory hallucinations? For example, they are going to listen like first person, second person who is commentary giving, okay, and next third person executing. This way they are going to listen. Next, made impulse, made violation, and made effect. Made effect. Next, in here, thought insertion, something is going to be inserted in our mind, and thought broadcast, which will be running always and continuously, and next thought withdrawal. So this is what Kurt Schindler said that. Okay, Kurt Schindler said this phenomena. Right, these are going to be the first rank symptoms which can be asked in the examination. Next, timelines for the diagnosis of the schizophrenia kind of diseases. So, okay, when I say that is schizophrenia conditions, what are the timelines that you have to remember? So, there are the three types, guys. First example is a schizophrenia. Okay, schizophrenia, it should be more than 6 months. Okay, the symptoms that should be present more than 6 months. Next, we also have the brief psychotic disorder, which should be less than 1 month. Okay, next, schizophreniform disease. This is 1 to 6 months. Okay, 1 to 6 months. So that is schizophreniform. Next, schizophrenia have the two types of the for these patients. What we have to see, the diagnostic criteria is more than 6 months that they have to have. But what is the defect that is present in the schizophrenia? Basically, in the schizophrenia patients, when I say schizophrenia, it is going to affect the two important pathways. One is mesolimbic pathway and other one is the mesocortical pathway. Okay, so the mesolimbic pathway is important for the positive symptoms. Okay, and mesocortical is important for the negative symptoms. So positive symptoms in the sense that the patient will be having the delusions, okay, and also hallucinations. Okay, hallucinations will be seen, and also they are going to have the disorganized behavior, which will be also seen in this patient. Next, negative symptoms, this will be apathy, okay, loss of interest and evolution, anhedonia, okay, and also alogia. So no logical thinking also, which will be seen in this patient. And effect is nothing but either they are going to be complete dull and silent. This is what effect. So these are the negative symptoms, and when these patients will be associated with this condition, at least 1 out of 3, okay, 1 out of 3 has to be positive for making the diagnosis of the schizophrenia for this patient. Right, next, there is also that you have to take note that these patients, those who are having the schizophrenia, they are better prognosis and they are worst prognosis also. So which will be deciding the better prognosis and which will be deciding the worst prognosis? So schizophrenia patients, those who are having the acute condition, okay, those who are having the acute condition and late age, then the patient will be mostly females, than males, and who is having the more positive symptoms rather than the more negative symptoms, and no family history of suicide or no family history of any disorders, and those who are associated with the mood symptoms, they are going to have the better prognosis. So then opposite to that, the who is having the late or chronic stages, and those who are having in the early age, and males those who are with the history and with the positive and also with the negative symptoms, and there is a history of the family with the suicide or with the mood disorders, and they are not having the mood symptoms. So all these are going to decide the negative and the worst prognosis for this patient, right? Next, coming to the schizophrenia. Nowadays, actually, from the schizophrenia, they are less asking about the schizophrenia, but they are more focusing on the antipsychotics. Okay, so now also we are going to follow on the antipsychotics only. So we have the typical and we also have the atypical antipsychotics. So when I say typical antipsychotics, these are going to be the first generation. These are going to be the first generation. Atypical, these are going to be the second generation type of the drugs. Okay, so first generation of the drugs, they are going to block the D2 receptors. They are going to block the D2 receptors. And next, these drugs is going to block the D2, they are going to block the D2, and at the same time they also going to block the 5-HT. So serotonin receptors is also going to be blocked by the atypical type of the drugs. So when there is a D2 receptors is going to block, other than that there will be a extrapyramidal tracts. So these extrapyramidal tracts will be having the exaggerations. So the more prominent symptoms will be seen in this patient. Whereas 5-HT is also blocking, so extrapyramidal symptoms which will be decreased in this patient. And other than that, this patient is always going to be have the neurotoxicity. Okay, and here these patients will have the more of the metabolic toxicity. Okay, metabolic symptoms will be seen in this patient. That is what antipsychotics types and their these different types of the functions will be seen in this patient, right? Next, moving on to the important points of about this typical and the atypical drugs. Okay, first, so what are these extrapyramidal symptoms and what is the treatment that we can give for this patient? So extrapyramidal symptoms are so and so. First, the most common within hours, that is dystonia. Okay, dystonia. And for this dystonia, what is the drug of the choice for the antidote, guys? Benzexol. Benzexol should be given. Next, another one. It is around days. Okay, this will be around days. And this patient will be having the akathisia. Okay, akathisia. The drug of the choice to antidote will be propranolol. And next, Parkinsonism. Though this is also days, this is Parkinsonism. And for this patient Parkinsonism, also the drug of the choice will be Benzexol should be given. Next, very late or any time on the drugs, that is going to be the tardive dyskinesia. Okay, that is tardive dyskinesia or the rabbit syndrome, also known as this one. So tardive dyskinesia. So for this patient, to decrease this, either you have to stop the typical drugs, and you have to start the atypical, right? And another antidote what we can give is the valbenazine. Okay, valbenazine, the drug can be given for this patient. Next, those who are associated with this one, there will be neuroleptic syndrome. Okay, neuroleptic syndrome. This is like a malignant hyperthermia. For this patient, the IV dantrolene should be given for this patient, right? These are some of the these are some of the examples that you have to remember. Okay, next, what are the examples, guys? Examples for this typical drugs such as haloperidol, and also chlorpromazine. Okay, risperidone. These are the some of the examples. Sorry, risperidone is belongs to second generation. Okay, so here examples are risperidone. So remember, risperidone will be associated with the hyperprolactinemia. And another drugs, olanzapine, and also clozapine, right? These are the some of the drugs. Next, second generation side effects, what we thought, guys, that is going to be have the second generation drugs. So their side effects is mostly what we discussed, metabolic syndrome, right? There will be increased metabolic syndrome. And for the clozapine, agranulocytosis is also seen. Agranulocytosis also seen, and seizures also seen in this patient. But this seizures is dose dependent. Okay, dose dependent, and zero metabolic effects. Zero metabolic effects that will be seen with the Z for zero, Z for Zipro. Okay, ziprosidone and ariprazole. These drugs will be having the less metabolic effects comparing to the other drugs, right? These points also that you have to remember. Next, also, which can be given for the resistant schizophrenia. For the patient, those who are having the resistant schizophrenia, the drug of the choice for this patient will be the clozapine. Clozapine should be given for this patient, right? And also, if the patient is suffering from the schizophrenia, how the treatment protocol is given, guys? First, we are going to start the patient on the atypical only. Okay, first start the patient on the atypical, and after 6 weeks, if the patient is not having any problem, then you have to go for the other drugs like typical. Okay, if there is no improvement, then you have to start the patient on the typicals. And if it is resistant, to treatment, then here you can see this is the drug of the choice for the patients of the resistant. Clozapine is given, right? Early atypical, we are not going to give the clozapine, right? This zero metabolic effects, this can be given for that patients. This is one thing that you have to remember for the schizophrenia. And also in the schizophrenia, you have also have the different types. Okay, schizophrenia can be having the different types also. For example, there is a paranoid subtypes. Paranoid, which is the most common type, and it is associated with a late and good prognosis. Late and good prognosis. And then you also have the catatonic, also good prognosis. And then heberprinic. So this is going to be the worst prognosis. Worst prognosis. Right? These are the important types of the schizophrenia types, subtypes that you have to remember, guys. Right, this completes our topic about the schizophrenia, their side effects, atypical drugs, and everything. Next, moving on to the depression. So when I say depression, this table is going to be important for you. First, look at this table, guys. This is euthymia, means our normal mood, right? If it is down, then that is depression. And if it is showing the two different variants, for example, it is again hypermania and then again dysthymia, then this is condition is bipolar. Next, again, like suddenly onset of the hypomania and then again dysthymia, this is bipolar 2. So what does mean by the depression? First, the depression patients will be having this at least 5 symptoms. What are these, guys? The patient will be having the lack of sleep, lack of interest of any doing, and he is always having the nihilistic behavior. Everything is happening due to him. Like guilty, energy, low concentration, low appetite, and low psychomotor activity, high suicidal ideation. All these symptoms will be seen in the patients of the depression, right? This patient will be having everything, these kind of things, that is for the at least 2 weeks periods. Then we say this patient is suffering from the major depression. Okay, this patient is suffering from the major depression. Next, mania, which is also known as a bipolar. So bipolar patients will be having the Dick Fast syndrome. So what is this Dick Fast syndrome? Not syndrome. This is like a mnemonic for you guys. Dick for the distractibility and easy frustration and irresponsibility, grandiosity, right? They will be having the grandiousness around them and flight of ideas. Activity increased with weight loss and increased libido, and sleep is decreased in this patient, and talkativeness. So the bipolar patients will be having the more than 4 weeks. Okay, bipolar patients followed by the depression episode. Then we can consider this patient is a bipolar type 1. Okay, next we also have the bipolar 2. So bipolar 2 patients is going to have the hypomania. Okay, so same symptoms can be seen, but less severity that will be seen with the patients of the bipolar 2. Next, cyclothymia. So cyclothymia means more than or equal to 2 years with the symptoms of hypomania. Okay, with the symptoms of hypomania. Next, dysthymia. Here, dysthymia is also more than or equal to 2 years continuous depression, that is seen with the depression, right? These are the some of the types and their symptoms associated with the depression disorders, right? In the depression disorders, one thing that you have to remember, guys, again coming back to our important points, drugs. Okay, drugs, and what are the drugs that we are going to give in this patient and how we are going to give. So first we have the typical depressants. Okay, first atypical and then typical also. Here the typical drugs are, typical depressants are SSRIs. What are these SSRIs, guys? Selective serotonin 5-HT, which is serotonin reuptake reuptake blockers, or which is known as a inhibitors. Okay, this is the first line of the therapy that we are going to give. Especially all the mild to moderate depression patients, we are going to give this drugs. So what is that common drug that we are going to give, guys? Fluoxetine. Okay, fluoxetine is given for this patient, and this drug is having the specific side effect. What is that side effect? Premature ejaculation. Okay, premature ejaculation that is seen in this patient. So for those patients, those who are having the condition like erectile dysfunction, for that patients we can give this drug, right? Dopoxetine. The drug is associated with the premature ejaculation is the dopoxetine, right? Next, but SSRIs is not only given for the depression patient. SSRIs, this SSRIs can be given for the following conditions. Okay, first, major depression disorder. For this also patients we can give this one, and also those who are suffering from the general anxiety disorder. Also patients those who are suffering from the OCD, and patients suffering from the phobia, PTSD, and also those who are suffering from the impulsive control disorder, right? All these patients, even bulimia patients also we can give this drug. That is for the selective serotonin drug and their choices for which patients that we are going to give, right? Next, we also have the atypical drugs. Okay, we also have the atypical type of the drugs. So these atypical antidepressants such as bupropion, bupropion for the smoking cessation, we are going to give this drug, right? And also we have the tioneptine. This tioneptine is going to increase the reuptake of 5-HT. Okay, this is going to increase the reuptake of patients with the suffering this condition. Next, there is a nasal spray. So there is a nasal spray which is known as a esketamine. Okay, this esketamine for those who are suffering from the resistant depression, we are going to give this drug. So these are the some of the examples, guys. Okay, these are very important for you guys to understand. And what happens, these typical depressants can cause one syndrome which is known as a serotonin syndrome. Okay, so serotonin syndrome, suddenly the rising of the flushing temperature that will be seen in this patient, right? This has to be treated immediately, withdrawal of these following drugs. Next, we are going to see about the SNRIs. Okay, these are also one of the antidepressants, but SNRIs will going to increase the 5-HT, which is your serotonin, and along with that, norepinephrine is also going to be increased in this patient. Next, what is the specific side effect that is associated here? Hypertension. The patient will be associated with the increased hypertension will be seen in this patient. Next, tricyclo antidepressants. Okay, this tricyclic antidrugs, what they will do, they are actually most lethal for the antidepressants. Okay, so if they are associated with the toxicity, so what is the drug of the choice to decrease this toxicity, guys? That is bicarbonate. Okay, bicarbonate should be given for this patient. Commonly the other side effects for these patients will be cardiac toxicity will be seen. Okay, weight gain, and also obesity, So weight gain, obesity, sedation, right? And also this will act as a anticholinergic. So if this is acting as a anticholinergic, obviously the patient will be having the constipation, dryness, and all these symptoms will be seen, right? So that will be associated with this condition. Next, and also the question can be asked, what is the drug of the choice for the patient those who are pregnant with the depression? Then the drug that can be given safely is the sertraline. Okay, sertraline can be given for this patient, right? Remaining all the drugs are contraindicated in the pregnancy. Next, we are going to see the lithium. Lithium is given for the which patient, guys? Commonly for the mania, we are going to give the lithium. But lithium is going to be half life is 24 hours. Okay, off life is 24 hours, but its plasma concentration is very important because it is going to have as a like a very different symptoms. Okay, so the basically the patient those who are taking the lithium will be associated with the specific symptoms, right? This is known as a acute toxicity. What are those? First, the patient will be having the nausea and vomiting, okay, which is commonly seen, and along with that the patient will be having the ataxia. Okay, so ataxia will be seen in this patient. Next, dysarthria will be seen. Next, first it is associated with the fine tremors. Okay, but over the time, if the toxicity is seen, that is going to cause the coarse tremors. Okay, and also nephrogenic diabetic insipidus, which will be seen in this patient. And if the mother is taking, then it can cause the Ebstein's anomaly, right? Ebstein's anomaly. And if we don't treat in the immediate treatment, this can cause the severe renal failure. So even hemodialysis is needed for this patient, right? So this is how lithium toxicity will be seen in the patients, right? That's why we have to see the patients, those who are taking the lithium, we have to understand if there is a the threshold is crossed or not. That we have to check for this patient. And also it can cause the thyroid also. Thyroid dysfunction is also seen with this lithium. Right, next moving on to the another types, guys, that is anxiety disorders. So in the anxiety disorders, you have to understand first what are the PTSD. What does mean by the PTSD? First we will see, and then we are going to move to the other disorders. Okay, first in the PTSD, before you going to know, there is a acute stress reaction. Okay, acute stress reaction, and also acute stress disorder, acute stress disease. So in this acute stress reaction, it is just less than 2 days. And acute stress disease, that is less than 2 months, or let's say it is just 1 month. Okay, this is less than 1 month. So these patient will be like symptoms are just shock, reaction, and confusion that will be seen in this patient. Next, acute stress disorder. This patient will be severely stressed, okay, and anxious will be also seen in this patient. But when it is comes to the PTSD, so PTSD, this will be seen with more than 4 weeks. Okay, that means more than 1 month for this patient. So this patient will be associated with the nightmares. Okay, nightmares, flashes will be seen, and also avoidance of that particular situation, that will be also seen in this patient. So they are actually hyper arousal with any kind of thought with that particular incident, that is seen with the post traumatic stress disease. And for this patient, what is the best drug of the choice for this patient, guys? Again, SSRIs should be given. Okay, fluoxetine or the paroxetine can be given, but the best treatment is going to be the cognitive behavioral therapy. That is the best treatment that we can give for this patient, right? Next, coming to the anxiety, first we have the panic disorder. Okay, first importantly you have to know about the panic disorder. So what is mean by the panic disorder, guys? It is associated with the acute attack. It is associated with the acute attack of intense anxiety, that eventually the patient will feeling like impending death. The patient will be feeling the impending of death. So this classic finding impending of the doom, impending of the death, that will be seen because they are associated with the all classical symptoms such as chest pain, and also breathlessness, right? Palpitations will be seen in this patient. And if the palpitation is very high, if this combined choking, hmm, and also dizziness. So sometimes they feel like they're already dead, feeling of dying and losing everything. That is seen in this patient. That is panic disorder, okay, which will be associated with impending of death. Next, generalized anxiety disorder. What is this generalized anxiety disorder? The symptoms that is almost lasted for the more than 6 months. That is known as a patients with the generalized anxiety disorders. Next, we also have the some of the other things. For example, phobias. Okay, that is agoraphobia. Okay, what is this agoraphobia, guys? Usually, if they are having more than or two situations, more than two or situation which will be fear for them for more than 1 month, that is considered as a agoraphobia. For example, public places and open spaces and also enclosed spaces, right? These kind of things, or patient in the line, crowd, okay, lift, and alone, all these places, open closes, closed spaces, lines, crowds, ellipse, alone also, everything will be in the patients of the agoraphobia. They are going to be fear for this situation, right? That is one of the other disease considered in the patients of the anxiety disorders. Next, we also have the OCD disorders. Okay, we also have the OCD, obsession compulsion disorder. So in the obsession compulsion disorder, it is usually associated with the insights. Okay, it is associated with the insight. Either the patient will be compulsion with the habits and also obsession to do again and again. So this will be present in this patient, right? That is known as a OCD condition. Next, under that also you have to know about some of the disorder. Body morphic disorder. Okay, body dysmorphic disorder. So in the patients of the body dysmorphic disorder, these patients will be usually associated with a perceived defect. Okay, they always think that something is wrong in their behavior, in their body. That's why they commonly check like mirror checking and also grooming. Okay, all this will be seen in this patient. That is known as a body dysmorphic disorder. Next, we also have the hoarding disorder. Okay, hoarding disorder, this patient will unable to discard. Okay, unable to discard. So whichever is invaluable thing also, they are going to save it. Invaluable is also going to be saved by this patient. That is known as a hoarding disorder. Next, we also have the trichotillomania. Okay, trichotillomania, this patient will be having the recurrent pulling of the hair. Okay, pulling of the hair that will be seen in this patient. And if they eat, that can be found as a trichobizarre. Trichobizarre, if they consume it. Okay, if they consume it, this can be seen in this patient. Next, excoriation disorder. Excoriation disorder, again skin picking disorder that will be seen in this condition, right? These are the some of the OCD related disorders. And for this patient, what is the drug of the choice, guys? Again, SSRIs can be given for this patient. Next, personality disorders. Here you can see cluster A, which will be seen as a odd eccentric type of the people. Paranoid, schizoid and schizotypal patients will be seen in the cluster A. Next cluster patients, like dramatic unpredictable patients. For example, antisocial, they are going to be avoiding every person. Okay, next, borderline disorder, they are going to be like dramatic and high suicidal risk will be seen with the borderline. Next, histrionic, like these patients, like they are very attractive to the everything, like they are going to be seductive and very dramatic, that will be seen with the histrionic. Like narcissistic negative people, like Hitler kind of people, and avoidant personality, complete they are going to avoid that persons. Next, dependent, they are dependent on the others. Next, obsessive compulsive personality disorder. So this is under the cluster C, anxious and the fearful. One thing that you have to remember, borderline. Okay, borderline patients are associated with the increased suicidal risk. Okay, and histrionic also after that. But most common is the patients with the borderline will be having the risk of suicidal, right? This is some of the important points that you have to take note. Next, coming to the postpartum. Okay, coming to the postpartum. So in the postpartum, we have the three types, guys. First one is the postpartum blues. So what is mean by the postpartum blues? That the patient with the postpartum blues or the baby blues, these patients, the symptoms will be mood swings. Okay, the patients will be having the mood swings, sadness and tearfulness. Okay, tearfulness and sleep disturbances, right? This will be seen in the patients of the postpartum blues. Next, another type is the postpartum depression. Okay, postpartum depression patients, they are all other symptoms. These symptoms will be seen. Okay, sadness, tearfulness, sleep disturbances, everything will be seen. But they also associated with the guilt. They also associated with the suicidal. Okay, suicidal and also harming the baby. Okay, harm in the baby. That is seen in the patients of the postpartum depression. Okay, this can be severe also. Next, other type is the psychosis. Okay, other type is the psychosis. So these patients with the psychosis, what happens? They are going to be like severely, they can harm themselves or the newborn. Simply, they are going to harm the baby, okay, harm the baby or themselves. Okay, this is seen in the postpartum psychosis, which is also known as a puerperal psychosis. Next, for this patient, the drug of the choice for this patient is the brexanolone. Brexanolone that can be given. Here, the drug of the choice is just supportive treatment. Okay, supportive treatment will be given. Here, the drug of the choice, again, here also we can give brexanolone, or you can go for the ACT also, elective elective conclusive therapy also can be given for this patient. Convulsive therapy also can be given for this patient, right? This is the things that you have to remember about the postpartum diseases and also clusters and other diseases. Next, moving on to the childhood disorder. Okay, in the child psychiatry, first thing, that is intellectual disability that you have to remember. So intellectual disability, which is a new word, but before that it is known as a mental retardation. So in the patients of the mental retardation, commonly how we are going to calculate the IQ, guys? So IQ is calculated based on the patient mental age and by the chronological age, which will be divided by 100. This is how we are going to divide. Next, what is mild? Usually 50 to 69 IQ, which will be considered as a mild. Next, moderate 35 to 49 IQ. Severe 20 to 34 IQ. Profound is even less than 20. Who is the most common affected? Most common genetic. Then it is patients, those who are suffering from the Down syndrome. Okay. And if it is inborn error metabolism, then it is phenylketonuria. Phenylketonuria is commonly seen with this patient. Next, for this patient, what is the assessment? What are the tests that we can perform for this patient? Especially the test will be worldwide. We are going to use the Visual test, Visual scale that we are going to use. And in India, Binet test. Okay, Binet Kamath test that we are going to follow, or Bhatia test also used for this patient. So this is how the patient, those who are suffering from the this specifically condition of this mental retardation that we are going to see. And other than this, we also have the some of the important disorders that you have to take note. Those are ADHD, right? Attention deficient hyper sensitivity disorder. So these patients will be having the severe condition more than 1 month. Okay, more than 1 month, and from the childhood they are going to have. And commonly asked question from this is the drug of the choice. Drug of the choice for this patient is the methylphenidate. And if it is non-stimulant, if it is a non-stimulant, you have to give the atomoxetine. Atomoxetine can be given for this patient. Next, we also have the Asperger syndrome. Okay, Asperger syndrome. But Asperger syndrome will be having the learning disabilities, learning disability. But this patient IQ is normal. Okay, that is Asperger. Next, Rett syndrome. Okay, this Rett syndrome is patient with the microcephaly, a microcephaly, and the gene that is involved here is the MECP2 gene mutation for this patient, right? After the 5 months of the age, the patient will be IQ is also going to be deteriorated for this patient because of microcephaly, Rett syndrome. For this patient, the drug of the choice is the profinitide. Profinitide can be given for this patient. Next, Sayer syndrome, that is known as a autism, and autism patients is commonly associated with the skills, right, especially the language and social skills, language and social skills that they are going to decrease. But again, IQ is normal in this patient. That is seen in the autism patient. Poor imagination, language, IQ, that will be affected, and social behavior, okay, that will be affected in the this patient of the autism patient, right? This is the things that you have to remember in the important points of this condition. Next, moving on to the stages, we have the different stages. For example, oral stage and anal stage and phallic. Okay, anal and phallic. Then we also have the genital, right? In these stages, what is the age groups that you have to take note? First, oral stage is from the birth or 0 years to 1.5 years patient. They are more interested about the like breastfeeding, oral, keeping the things into the mouth. That is oral stage. Next, anal stage 1.5 years to 3 years. So here they are more going to for the bladder, bowel, all movements that will be seen. If there is a effect, then the patient will be going back to the OCD. Next, phallic stage. This is about 3 to 5 years. Okay, they are learning about their gender identity and everything that will be seen in this patient. But if it is not properly fixed, then the patient will be suffering from the electrocomplex or the Oedipus complex that will be seen in this patient, right? Like hysteria or borderline diseases that will be seen in this condition. Next, genital stage. In the genital stage, again 12 years, more than 12 years, that the patient is going to be like adulthood. So morely they are going to be into the genital side. Okay, genital functioning, how they are going to be engaged, everything that will be seen in this patient, that is seen in the genitalia. Right, this is the genital stages. These are some of the important points that you have to know about these stages. Next, moving on to the substance disorders that you have to remember. First, see the toxication and important points related to them. First, we are going to discuss this is barbiturates. These are the barbiturates, and here these are benzodiazepines, and here these are amphetamines. Okay, amphetamines here. Next, we will see the other plants also. First going to the barbiturates. What is the main mechanism of the barbiturates, guys? Usually barbiturates is going to act as a GABA receptors. Okay, they are going to increase the GABA receptors. Right, this is commonly seen with the patients of the barbiturates intakes. So intoxication with the barbiturates, how it is going to be presented. So the patients will be having the marked respiratory distress. Okay, marked respiratory distress that will be seen in this patient, right? There will be a increased blood pressure and there will be a respiratory distress for this patient. You are going to see that is the intoxication. Next, when it is comes to uh, the patient's withdrawal. So in the withdrawal, those who are taking the barbiturates, commonly seen with the delirium. Okay, delirium can be seen in this patient, and also cardiovascular collapse. Cardiovascular collapse is also seen in this patient. Right, next, moving on to the benzodiazepines. Again, benzodiazepines is also act as the same. They also going to increase the GABA activity. Okay, when they are going to be the positive GABA activity, that will be crossing the blood-brain barrier. So this patient usually associated with the ataxia, movement in walking, and when they also seen with distress in the respiration, that will be seen in this patient. And these patients, again, BP is increased. Whatever the patients, those who are taking for the withdrawal, there will be having the seizures, okay, and also sleep disturbances, depression, that will be seen here. Next, coming to the amphetamines here. Okay, amphetamines patients is usually those who are taking intoxicated. Euphoria will be seen. Midriasis, midriasis will be seen in this patient, and also skin excoriations, like rubbing themselves, skin excoriations will be seen, and increased alertness. Okay, increased alertness, sometimes increased BP, that will be also seen. And patient always going to be wakefulness, that is seen in the patients those who are taking the amphetamines. So usually amphetamines is going to increase the what are things, guys? For example, they are going to increase the neurotransmitters in the brain, neurotransmitter. That's why there's sudden energy, euphoria, alertness, wakefulness, that will be seen in this patient. So there is no glycine things, only always excitatory, dopamine, that kind of things will be increased in this patient. And next, in this patient, those who are going to have this, like patient is going to have the withdrawal, they will be having the tactile hallucinations. Okay, tactile hallucinations. So these tactile hallucinations, what happens? Something is crawling on them, some mites are crawling on them, that will be seen in this condition. Next, know that this drug of the choice for this patient, what we can give to decrease this condition is the flumazenil. Okay, flumazenil can be given for this patient. Next, here you can give the drug of the choice, that is lorazepam should be given, benzodiazepine should be given for this patient. Okay, next, here you can see this is the opioids. These are opioids. Next here, this is your cocaine. This is cocaine. And here, this is the cannabis. So let's see what are these. First, opioids is going to be depressant. First thing, right? Opioid is the depressant. This is going to modulate the opioid receptors, and we're going to see. Next, what is the intoxication symptoms? Okay, what are the intoxication symptoms? Okay, simply the patient will be having the pinpoint pupils. Okay, that means meiosis will be seen, and there will be decreased respiratory rate, and also patient will be having the gag reflex, that will be seen. And also when the patient will be having these pinpoint needles, there will be decreased GI motility, and everything will be going to this patient, right? That is seen with this condition. Next, when it is comes to the withdrawal withdrawal of the condition, so the patient will be having the opposite, right? Midriasis, so GI motility will be increased, so diarrhea. So when there is a diarrhea, that the patient will be having the low BP, hypotension, right? Vomitings, vomitings and sweatings, perspirations, right? This patient will be seen, and lacrimation, that will be seen in this condition, right? This is what we are going to see in the patients of the intoxication and the withdrawal. When it is intoxicated, the drug of the choice that you have to give naloxone. When there is a withdrawal, you have to give the methadone. Accordingly, we have to give. Next, coming to the cocaine. Okay, in the cocaine, this is going to block the dopamine. Okay, first it is going to block the dopamine. So when it is block the dopamine, it is going to cause the psychoactivity, right? There will be a stimulant. It is going to act as our CNS stimulant. So what is the toxication symptoms? Intoxication associated with the cocaine is commonly patient will be having the midriasis. Okay, midriasis will be seen, and along with that, hallucinations, and also paranoia, angina, like chest pain will be seen in this patient, and also sometimes there will be nasal septal perforation will be seen, right? Remember nasal septal perforation associated with this condition, which will be vascular necrosis, that is also seen in this condition. If there is a high dose intake, if they are taken, angina, chest pain, and even sudden death is also seen in this patient, right? So for this patient, the drug of the choice is the benzodiazepine that you have to immediately give. Next, withdrawal. In the withdrawal, you are going to see the restlessness, hungry, severe hungry, that will be seen, and sleeplessness will be seen, and also hungry, high hungry, and sleeplessness, very active, restlessness the patient will be having, and even depression. Okay, depression is also seen. Next, coming to the cannabis. Cannabis can be commonly known as you are going to increase the hallucinogen. Okay, it is like a hallucinogen. So what happens when you take the patients, those who are taking the cannabis, intoxication will be seen. So in the intoxication, the patient will be having the anxiety. Okay, delusions will be seen in this patient, and improper judgment is also seen, and appetite, increased appetite will be seen, dry mouth, and classically you are going to see the patient with the hallucination, delusions, euphoria, those all are going to be seen. Next, when the patients, those who are going to be the withdrawal, so patient those who are having the withdrawal, again anxiety will be seen, okay, and depression, anxiety, depression, and also insomnia. Patient will be having the insomnia and decreased appetite, and sleep disturbances that will be seen here. This is known for the cannabis, right? These toxications and important things that you have to take note, guys. And another things like LSD is also going to have the same symptoms like the this condition only, right? Amphetamines only, it is going to have the LSD also, that you don't have to mostly have to remember. Next, coming to here, this is smoking. So smoking, which will be related to the nicotine, right? What does it is going to do? It is going to increase the nicotine with a help of acetylcholine, right? This is how it is going to stimulate. What happened? This is going to give the stresslessness, relief, and also restlessness. Okay, next, but when you have the withdrawal of the patients, those who are taking the smoking per day 60 sticks, something 30 sticks, they are going to have the complete anxiety, okay, recurrent anxiety attacks or the panic attacks. The patient will be having the irritability and increased stress that will be seen in this patient. Okay, nicotine. And for these patients, nicotine patients, there is a therapy that we have to follow. Okay. So what are those therapy that you have to follow for the patients with the nicotine? First, smoking is cessation. The smoking cessation therapy, how it is going to be given? It can be given by the nicotine replacement therapy. Nicotine replacement therapy. How we are going to give? It can be given in the form of the gums, lozenges, okay, and also cigar shapes with not the nicotine content, that can be given for this patient. Next, bupropion, okay, which will be act as a increased 5-HT, right? This can be also given for this patient. Next, varenicline, varenicline. So this is actually going to be artificial increase the nicotine, okay, without the cigarette it will going to be increased. So that is why these kind of drugs can be given for the patients those who are suffering from the smoking. Next, coming to the alcohol, we have to take note about the alcohol. So basically the patient those who are taking the alcohol, it is going to be either the patient is going to have the severe condition, right? So or the patient will be having the other. So basically in the alcohol you have to know about the withdrawal disorders. Okay, withdrawal disorder. So what happens when you stop drinking for less than 12 hours? If he is a chronic alcoholic patient, what happened? This patient will be having less than 12 hours. The patient automatically having the high heart rate, and the patient will be having the sweating. Okay, and the patient autonomic activity will be started less than 12 hours. Next, 12 to 24 hours, the patient will be having the hallucinations, and most commonly in the alcoholic patient, auditory hallucinations will be seen. Next, those who are having the 48 hours, less than 48 hours, this patient will be associated with the seizures, okay, alcohol withdrawal related seizures. And if it is less than 72 hours, then you are going to see the delirium tremens, okay, delirium tremens that you are going to see for this patient, that is commonly seen. Next, alcoholic can be seen as a Wernicke's encephalopathy, which will be GOA. What is meant by the GOA? Global confusion, ophthalmoplegia will be seen, and ataxia, right? And if it is progressed, it can cause the Korsakoff syndrome. Korsakoff syndrome. In the Korsakoff syndrome, you are going to see other symptoms like chronic stages. They are going to have the confabulation. So what is meant by the confabulation, guys? That the patient is going to fill the memory with the gap. And next, anterograde amnesia and decreased timing levels will be seen in this patient, right? So this is how Wernicke's, Korsakoff, and the withdrawal effects of this patient will be seen. And for this patient, what we can give, again, benzodiazepines should be given for this patient. Lorazepam, here again, lorazepam is the drug of the choice, and here long-acting benzodiazepine should be given. Long-acting benzodiazepine should be given for this patient, drug of the choice, right? This is the points that you have to remember for the alcohol therapy, okay, alcohol withdrawal. And whenever you see this condition, you have to immediately treat with the supportive therapy and associated drugs that you have to give for this patient. Next, moving on to the sleep disorders, guys. So first thing that you have to remember, sleep will be associated with the, what are the important that is for the sleep? Melatonin, okay, melatonin hormone is very important, and also adenosine, okay, adenosine, galanin, and GABA. So these are going to be like a sleep promoting factors. Next, sleep is divided into the two stages. One is non-rapid eye movements, and another one is the rapid eye movements, okay. So again, this is subdivided into the N2, N3, and N stages, and here it is only one stage, that will be paradoxical sleep. So let's see what are the sleep stages that is important for us to understand. First, stages of the sleep, usually you are going to be start with the awake, right? Then this awake stage, then you are going to next moving on to the REM stage, okay? Then we are going to move into the NREM stage, okay? In the NREM stage, we are going to have the first N1, then N2, and then N3. So let's see each and every stages. For example, first, awake is usually associated with the beta waves, okay. This is associated with the beta waves around more than 14 hertz, okay. And this is seen in every lobe except occipital, okay. In the occipital lobe, you are going to see the alpha, okay, 1 to 14 hertz you are going to see. This is alpha seen in the occipital, and beta wave seen in the frontal, temporal, and parietal lobes. Next, moving on to the REM stage. So during the REM stage, it is still beta waves. So this comprises almost 25% of our sleep. Okay, and sawtoothing will be also seen in the REM stage only. Next, NREM stages. This is known as a myoclonic or the micro sleeps. First, N stage is a very short. Okay, this is very short, associated with the theta waves. This is associated with the theta waves, and 4 to 7 hertz will be present. And where you are going to see hypnic jerks, right? Hypnic jerks you are going to see in this phase. Hypnic jerks that you are myoclonic jerks you are going to see in this phase. Next, N2 is going to be almost 45% of our sleep, where you are going to see K complexes and sleep spindles, spindles, which will be seen in this phase of the N2. Next, N3 is again is going to be delta waves, which will be seen in the NREM stage. Next, how can you interpret? This can be also asked in the examination. So these are the beta waves. Okay, these are the beta waves more than 14 hertz. Next, NREM stage alpha, and alpha is 1 to 14, right? 1 to 14 hertz. Sorry, 7 to 14 hertz. Next, stage 2, where you are going to see theta waves. This is 4 to 7 hertz, 4 to 7 hertz. And NREM delta, this is like less than 4, okay, less than 4 hertz that you are going to see. Again, REM stage, this is also going to be like mostly beta waves that you are going to see, but less beta waves that you are going to see. This is how we are going to interpret the sleep cycle. And next, coming to the sleep disorders, and what are the drug of the choice that we can give for this patient, that you have to take note. Next, only not all the examples that you have to know. First, most commonly, insomnia. So how much insomnia is considered as a disease, guys? Basically, if it is more than 3 nights per week, 3 nights per week, or the consistency more than 3 months, if the patient is suffering, adapting for the sleeping or maintaining, initiating, that is all considered to be the insomnia. Next, narcolepsy. So what is meant by the narcolepsy? That will be associated with the cataplexy, right? That will be associated with the cataplexy. Irresistible, that the patient will be irresistible to sleep. Suddenly they are going to talk, and again they are going to sleep immediately. That is seen in the patients of the narcolepsy. And also we have the other OSA. What is this OSA, guys? Obstructive sleep apnea syndrome. And also this will be due to snoring, right? This will be due to snoring, obstruction in the airway, that will be seen in this patient. Next, what could be the drug of the choice that can be given for this patient? The drug that we are going to give the patients, commonly here we have to increase the GABA activity, and GABA activity can be increased by the benzodiazepines, right? Benzodiazepines can be given for the drug of the choice for this patient. Next, narcolepsy. Here the drug of the choice for this patient is the zolpidem. This zolpidem, or whichever is going to be act on the GABA, same we are going to give for this patient. And also melatonin drugs. Okay, melatonin drugs can be given for this patient, right? These are the some of the drugs we can use. And the only drug of the choice for the patients of the narcolepsy is the modafinil. Okay, remember, this is modafinil can be also given for this zolpidem is going to increase the GABA activity. Yeah, that is why zolpidem is the drugs that we can use. But only narcolepsy, if they ask a drug of the choice, modafinil that you have to choose. Next, food disorders. So in the food disorders, there are some of the important points that you have to take note between the binge eating, bulimia nervosa, and the anorexia. So first we will see the bulimia nervosa. So what happens in the patients of the bulimia nervosa? Basically, this patient's BMI is normal. Okay, BMI is normal, but still this patient will be associated with the binge eating. Okay, they are going to have the binge eating, and along with that there will be purging. Okay, self vomiting will be seen in this patient. So that's why these patients will be suffering from the all kind of the disturbances. But when it is comes to the anorexia, this is somewhat better because BMI is normal, and this induced vomiting or associated with the laxatives, taking excessive laxatives, that will be seen in the bulimia nervosa patients. Next, anorexia nervosa. So anorexia nervosa patients, this is commonly seen in the early adolescence that we are going to see, and completely low BMI or less than 25% of normal body weight that they are going to have, and extreme fear to weight gain. Extreme fear to weight gain is seen in this patient, and also distorted body image is seen, like skeletal that can be seen in this patient, and associated with the amnoria. And when you check the blood vessels, blood picture, that is going to be anemia. And this all associated with the suicidal risk also. a suicidal risk. So that is seen in the patients of the anorexia nervosa, which is more severe, guys. This is more severe comparing to the bulimia nervosa. Next, we also have the binge eating disorder. Okay, binge eating disorder. So what is seen in the patients of the binge eating disorders? So here these patients will be obese or overweight. Okay, and seen in the young adults patient. They are actually more of the eating. Okay, more eating, more and more. Heavy meals will be taken at a time. Heavy meals and isolated eating, but there will be associated guilty after eating. Guilty after eating will be also seen in this patient. Next, Pika eating non-nutritive things. That is known as a Pika seen in pregnancy and also childhood. Children, especially children, you are going to see this condition. Okay, next we are going to see some of the other disorders, guys. For example, delirium. Okay, in the delirium, you have to take note that delirium is most commonly seen in post-surgery post-surgery or ICU patients. Okay, so what is mean by this delirium? So first thing that you have to understand that the delirium is an emergency condition where the patient is alertness and the patient among the alteration, okay, alteration in the sensorium will be disturbed here. Okay, so that will be causing the patient sleeplessness, okay, sleeplessness, and also there will be slow EEG will be seen in this patient. Slow EEG will be seen in this patient. What is the test that we can perform on this patient is the mini mental status examination that we can proceed for this patient, right? Next, what is the treatment? Treatment of the choice for this patient is benzodiazepines. Benzodiazepines can be given for this patient. That is known for the patients of the delirium. Next, coming to the dementia. So in the dementia patients, how we are going to see? This is most common neurocognitive disorder. Neurocognitive disorder. So dementia can be many types. Okay, it can be associated with the reversible or the irreversible. Okay, it can be reversible, such as vitamin B12, hypothyroidism, okay, and also head injuries like acute trauma, and also patients those who are suffering from the normal pressure hydrocephalus infections. These all are going to be the reverse. Next, we also have the irreversible like Parkinson's and Alzheimer's, Lewy body, Lewy body dementia, or the vascular dementia. These are the severe dementias and irreversible dementias. Okay, these are some of the things that you have to remember about the what are the types and what are the other types that you have to take note. And Alzheimer's and the Parkinson's, that is discussed in the neuro medicine part. You can refer that, guys. Next, last things like some of the miscellaneous definitions you have to take note. Sorry for the cough, guys. So we'll see the classical conditioning and operant conditioning. So classical conditioning means that the patient is learning from the natural response. The patient is learning from the natural response, which is conditioned or learned stimulus that is previously prosecuted in the patient purpose only. Okay. So for example, let's say the patient is learning from the natural responses means involuntary. Okay, involuntary response only. For example, let's say that the patient is showing the dog this one, do 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 do, wrong, wrong, wrong. It's gone. Next, we are going to learn some of the important points, right? Some of them is the classical conditioning. Okay, let's see. Classical conditioning. So what is meant by the classical conditioning, guys? This is given by the scientist Pavlov. Okay, what he said that, so whatever we are going to learn, that association is between two stimulus. Okay, it is between two stimulus, not just one, it is going to be two stimulus, but that is associated with the involuntary and passive process. Okay, the response we are going to give, that is associated before the response. That is what he said. Next operant conditioning. So operant conditioning is given by the scientist Skinner. So what does the Skinner is say that association is between the behavior, association is behavior and consequences. Okay, consequences. Whatever you do is going to come back. So it is active and obviously it is volunteer and associated with the central concept that is seen with this patient. Next, we also have the id, ego and superego. So let's see what are those id, ego and superego. So what is meant by the id? So id is going to be the primitive. Okay, it's always about the pleasure principle. It is going to be pleasure principle, like libido or this kind of aggression, that will be id. Next, ego is rational and reality principle that will be seen. Next, super ego is about the moral and morality principle that you are going to see. Next, transference and the counter transference. What is mean by the transference and counter transference? So transference means that the patient feelings towards doctor. Okay, this is the transference. Next, counter transference. Counter transference. Here, the doctor feelings to patient. So these are the some of the definitions and types that you have to take note, right? This is our discussion of the psychiatry. Please do take note of these important points and read. Okay, so thanks for joining this session, guys. Happy preparation. Those who are new to this channel, please do subscribe and stay tuned for the sure short topics of the 3 parts.